simultaneously. I think sometimes you end up digging your own grave, especially when you are a part of scientific committee and you choose a topic which is the most controversial, and that too when the organizers ask you to finish it in 9 minutes. So going to the question, like the metastasis presentation, as we all know, is the most significant negative prognostic factor in osteosarcoma, and most common metastatic site is lung. So more or less our talk will be more focused on the lung metastasis, and we'll be covering the other sites as and on when it is required. So for the purpose of this talk, I think there is no confusion. In the lung only relapsed in the osteosarcoma. When the patient relapses in the lung or at any other site, we know that the second complete remission is the goal. So there are not much confusion in this when the patient relapses in osteosarcoma. So the current problem that we are dealing is a metastatic osteosarcoma, which is a primary metastatic osteosarcoma. So the questions that we need to answer here is like, are all the lung metastases same in terms of the number, laterality, timing, the size and the site? What about the other sites like bone or the lymph nodes, or what about the combined metastases? What is the maximum number of a metastasis that can be removed? How to decide like when not to offer a metastatectomy? How good is the CT scan of the chest to guide us in planning a metastatectomy? And what is the ideal technique and the timing? So these are the questions that we want to answer, and frankly there is not much of a clear-cut evidence to answer this question, but we'll try to summarize as like whatever evidence that we have. So the most common question that we face in a tumor board is in the lung metastasis is what is the number, that is the number of the lung metastasis, and the laterality, that is unilateral or bilateral, that has to be decided whether this patient should go for surgery or not. There is some data which will try to answer these questions. The first study is by a French group which had actually a 78 patients in pediatric age with a 5-year overall survival of 19%. They found in univariate analysis that the number of lung metastases more than 8 show the poor outcome. More than one metastatic site has a poor outcome, and complete resection of metastasis is mandatory if you want to have a significant prognosis better than the other group. They also actually divided the metastasis in disease into a low risk metastasis when the alkaline phosphatase is less than 500 and when there is a resectable single metastatic site, and high risk disease when the alkaline phosphatase is more than 500 and there is more than one metastatic site or there is an unresectable metastasis. So on multivariate analysis, they found that patient with at least one of these poor prognostic factors had only 2.6% event-free survival at 5 years despite the treatment. So what they suggested is to use an experimental treatment if the patient is having a more than one metastatic site with a high alkaline phosphatase and an unresectable metastasis. And they also found out that none of the patients who had more than 2 metastatic skeletal sites have survived. So this is another good paper of lung metastasis in osteosarcoma, and they actually classified the lung metastasis into 4 groups. Group 1 at presentation, Group 2 during initial chemotherapy, Group 3 during post-operative chemotherapy, and Group 4 at the end after completion chemo. And what they found out is a very significant result, like Group 2 and Group 3, which are during the chemotherapy, they actually have no long-term survival. The best survival is when there is a relapse in the lung, and even at presentation, there is some survival, but there is no survival when the lung relapse happens during the chemotherapy. So what they found out also is that there is no difference in overall survival in all the groups when the patient did not undergo a metastatectomy. So basically, only a surgery is making a difference in the different groups. If a patient is not getting a surgery, then there is no difference in the survival. And only few patients in group 1 had the potential to survive for a long time. And most important factor here was a complete response to chemotherapy. And patients in group 2 or 3, which are metastasis developing during chemotherapy, had little or no possibility of survival, even when the response to chemotherapy is good, and even when there are less than 3 nodules. So basically, this paper concluded that either only a group 1 at presentation or at relapse, there is some chance of survival. Another paper, which is a COS group, cooperative sarcoma group of 202 patients, they also divided metastasis into different locations. And as you can see, that the skip is doing better than lung is doing better than other sites, and the combined metastasis is doing the worst. As far as the lung metastasis is concerned, the number of metastases is a significant prognostic factor. Same was the unilateral versus bilateral. As far as the other sites are concerned, so this on the left shows a number of metastatic site, which is 1, which is 2 to 5 or more than 5. And the lesser the site, the better is the prognosis. And same was the response to chemotherapy. A good response had a better prognosis. So what this paper concluded was the best prognostic group was solitary lung metastasis with overall survival of 75% at 5 years. Skip lesions had a better prognosis. Metastasis to distant bone was detected in 22% of cases, and 2/3 of
Hello, Randeep sir.
Yes, I think we lost Manish.
Yeah, Dr. Manish has lost his internet connectivity.
I think it's okay. I thought there is a problem with my screen. You can just wait for a second or a minute because sometimes he may be just reconnecting. Else we will shift to the second talk. Dr. Laskar is ready.
Yeah, sorry, sir. I think,
please come. Yes, sir, we are waiting for you. Manish, please continue.
So I don't know from where I missed actually. So
I think you will at the solitary met has the best prognosis, and then you can take it forward from there.
Sorry, yeah, I am very sorry. I think there's some net glitch. So yeah, so let's go to this paper, which is a cost group paper.
Next slide. This was covered.
This was covered. Yeah. So we'll go to this. The outcome of this study, which was the best prognostic group, was the solitary lung metastasis. Skip lesions also had a good prognosis. Metastasis to distant bone were very bad, and 2/3 of them had a widespread disease, with 85% of them died in median 1 year. And resectable metastasis should be resected regardless of number and localization. Another paper which also actually divided the lung metastasis into the same categories: group 1 at presentation, group 2 during chemotherapy, and group 3 after chemotherapy completion. And the outcome was also similar. The group 2 was doing worse. Another important finding by this paper was the patients in group 1, which is at presentation, less than 3 nodules had a better event-free survival than more than 3 nodules. So how to decide when not to offer and what is the maximum number that can be resected? Many factors are important here, but I admit that there is no correct answer. Surgeons have removed as much as 250 metastases from the lungs. And as mentioned previously, metastasis developing during chemotherapy is very bad. Multiple metastatic sites is very bad. And more than 8 metastases or 2 skeletal sites carries a very poor prognosis. Coming to the location of metastasis, this paper actually have analyzed between the central versus the peripherally located metastasis. And they found out that the centrally located may require anatomical resections, and centrally located which were close to bronchus or blood vessel. And what they found out was there was no significant difference in the type of surgery, which is lobectomy versus wedge. However, 3-year survival probability was 41% with peripheral lesion as compared to 7% with central lesions. And why this was happening, they could not actually give an explanation, but they thought that central lesions had more extrapulmonary disease, which came lately. And how good is the CT scan to guide us? This is a good paper from MSKCG which analyzed 54 consecutive metastatic in 28 patients. And they found out that the correlation between the number of lesions identified by the CT and number found during the surgery is not there. And also CT scanning underestimated the number of viral metastases in almost 26% of cases. So what they found out is what their conclusion was, even with advanced CT, there is a very rough correlation. In more than 1/3 of cases, metastasis would have been missed by any technique besides manual palpation. And minimal access surgery should not be the procedure of choice if the goal is to completely remove the metastatic lung lesion, which is the most important prognostic factor in a primary metastatic osteosarcoma. Coming to the timing of metastectomy, I think we can do at the time of index surgery or after the chemotherapy conclusion. And timing is decided on case-to-case basis based on the extent and duration of index surgery and the type of metastectomy surgery which is planned. Like suppose there's a unilateral metastectomy, you can do with an index surgery. Suppose there's a bilateral, you can do one at the time of index and one after the chemotherapy completion. But there is a data which suggests there is no difference in outcome as long as the complete resection is obtained, whether you are doing at the time of index surgery or after chemotherapy completion. So to conclude, solitary pulmonary metastasis have the best prognosis. Unilateral disease, few nodules, and peripherally located disease behave better. Metastasis developing during chemotherapy have a very poor outcome. Surgical resection of all the sites can only offer cure. More than 2 skeletal sites have also a dismal outcome. And metastectomy can be done at the time of index surgery or at the time of chemotherapy completion. Thank you very much. I am done, Dr. Randeep.
Thank you, Manish. I think Dr. Ukku sir is there, or Dr. Harit sir is there to take the session, and we can invite the next speaker, sir.
Is Dr. Harit there? Dr. Harit? Okay.
Yes, sir, please go ahead.
We now go to the second talk, which is by Dr. Siddharth Laskar from TMH, who will speak on radiotherapy in Ewing sarcoma, indications in current practice. Dr. Laskar, please.
I hope you can hear me.
Yes, go ahead.
Thank you. So I'll play the screen. So I'll spend 10 minutes on radiation therapy for Ewing sarcoma, the indications and the current practice. Just a little bit of demographics before I go into the real topic. It's the second most common primary osseous malignancy in children, and most of them would have the tumor at the age around 14 years. So that means they are relatively young age. What is the site that is normally involved? The pelvis and the centroaxial skeleton, most commonly involved, and followed by the extremities. Now, this is important to understand because when we use radiation therapy, the location of tumor has significance in terms of ability to deliver the dose of radiation and the ability to deliver avoid normal tissue toxicity. I might be able to move it. So radiation has played a major role from many years. And if you look at the data that is published in the 1950s in the New England Journal of Medicine, where the investigators used radiation therapy alone compared to radiation with surgery and surgery alone. And you would see that with a dose of 600 to 6,000 centigrade, the local control rate with radiation alone was extremely good of 72%. And but there was a downside. Although the local control was very high, the survivals were poor because many of these patients failed distally. Now, over the years, we've had many of these trials, right from the intergroup Ewing sarcoma study starting in 73 till the COG studies, the most recent COG and the Euro-Ewing trials. Now, if you look at the broad thing of the local therapy that was used in them, 40% of them would have surgery as the local treatment. Another 30% would have surgery and radiation therapy. And another 30% would have to be treated with radiation therapy alone. So in all, almost about 60% of patients would end up receiving radiation therapy at some point in time. Now, based on the evidence that we have had over the years, the current standard of care for treatment of Ewing sarcoma is neoadjuvant chemotherapy and followed by local treatment. And the local treatment of choice as of now has been surgery. And wherever possible, surgery is the treatment of choice. And radiation therapy is added for patients with unfavorable pathological features and for patients where surgery is not feasible. And that's where you see the indications of radiotherapy in a post-operative setting where the margins are close or involved, where you have gross residual disease, where you had a pathological fracture pre-treatment, or the necrosis was poor following chemotherapy. And of course, all those patients who cannot undergo surgery would receive definitive radiation therapy. Now, most of the data that we would discuss comes from this large database of 1,056 patients from the ICAS 92 trials. And if you look at the outcomes based on definitive radiation therapy versus preoperative radiation therapy versus postoperative radiation therapy, one could see that wherever you did surgery followed by postoperative radiation therapy, the local controls were the best. But the second malignancies between radiation therapy alone versus surgery and post-op RT and the incidence of distant metastasis were more or less same. So this is important to remember. If you dive deep a little bit and look at what is the difference between definitive RT versus pre-op RT versus post-op RT, and of course there was no radiation in this favorable group. So if you look at local controls, when you use definitive radiation, because of the selection bias, the local controls were 25% in the definitive RT, and the local recurrence was 25%. And in the rest of them, it was more or less the same, ranging between 5 to 7%. In the most recent Euroiving 99, the local recurrences between surgery and surgery plus post-op RT were in 10 to 12%. Volume of tumor is important when you're using radiation therapy alone, but the significance is lost when you're doing post-operative radiation therapy. If you go across to the US and look at the outcomes there, it is pretty similar. The outcomes with radiotherapy would be slightly inferior compared to surgery plus post-op radiation therapy. Now, I'll just touch upon quickly on these factors. What is the best timing of radiation? What is the impact of necrosis, surgical margins? What is the ideal radiotherapy target volume? What is the radiotherapy dose, fractionation, role of lung bath, and of course, one can't do without protons and carbon ions. So looking at timing, what is the best time to put radiotherapy into the combined modality treatment? If you base on the CESS 86 and 81 trials, the timing of RT is best done at around 9 to 10 weeks. And that is what the standard protocols would do. We would finish the induction chemotherapy. When the volume is least, we would do our surgery. If not surgery, then we'll go out with definitive radiation therapy or post-op RT. The other question that many of us ask is that, what is the time that you can delay after surgery before which you should be starting radiation therapy? Now, there is data from Andrei Schuck and his group from Germany, from the CESS and the ICAS studies. It is seen that there is no difference between starting radiation very soon versus starting radiation up to 60 days. So there is still benefit if you start radiation up to 60 days. Is there any benefit of adding radiation therapy in poor responders to chemotherapy? Now, the ICAS 92 was the group, the German group, where they showed that 90% necrosis was a factor. And so if you had less than 90% necrosis, it was better to add post-operative radiation therapy. And did it help in improving outcomes, the addition of radiation therapy? Yes, in patients who had poor response to chemo, the addition of radiation improved outcomes from, it reduced the recurrences from 12 to 5%. But the question is, what is good necrosis? And at what necrosis does radiation give you benefit? This is controversial. This is still gray. The CESS and ICAS study says 90% necrosis is the cutoff. Jay Wonder and his group from Canada say that it is 90 to 100%. Odile Oberlin and the group from France, from the SWAP, shows 90 to 95%. So broadly, we know anything above or below 90% makes a difference. But what is most paradoxical is that the recent Euroiving's trial, where they found that patients with 100% necrosis actually had the most benefit with adjuvant radiation therapy. Now, what about surgical margins? If the surgical margins are not good enough, is there any impact of radiation therapy? So yes, this study shows, published in Cancer, there is an improvement with addition of post-operative radiation therapy if your margins are not good. And the benefit was large in the study from Bachi et al. From Rizzoli. And there was almost 16% improvement in outcomes with addition of RT in poor in inadequate margins. If you had a marginal resection, then the benefit of post-op adjuvant RT is slightly is not as significant as shown in the ICARE study. But if you had a intralesional resection, there was a larger benefit. And what they concluded in the ICARE was that having an intralesional resection is as good as treating radiation with radiation therapy alone and no surgery. The portals from the POG 8346 trial, this is a randomized trial randomizing between whole bone radiation versus involved field. So what they proved in this study was that it is not necessary to treat the entire bone. You can just treat the involved field, the small, so that you can reduce toxicity also. Now, people have also tried to reduce the volumes of radiation therapy so that you reduce toxicity, especially in children. And they took a reduced margin to 1 centimeter. And people have also looked at trying to increase the dose of radiation in large tumors, 64.8 gray at 1.8 gray. So what they found was that by reduction in volumes, you don't compromise on local control. So that is, reduction in volume is possible. And the increase in dose of radiation does result in an improvement in local controls. Now, we did this in our randomized controlled trial. This is in the process of publication now. This is the only randomized controlled trial looking at dose escalation in inoperable Ewing sarcomas. And as you can clearly see, there is a significant benefit in the local control. So we will discuss about this trial later on, not today. Now, what about other studies?
30 seconds left. Yes, sir. Apologies, sir. 30 seconds left. Please conclude.
Okay. So fractionation is another factor. Hyperfractionation has not helped in improving local controls from this study. And what about lung bath? Lung bath or whole lung radiation has benefited in terms of disease control in the lung. Proton beam therapy has the benefit of sparing normal tissues and escalating doses. And there is data from Mass General Hospital showing that the local controls with proton beam therapy at 3 years is 88%. Similar outcomes from the European group with excellent outcomes with local control with proton beam therapy, and also with carbon ion therapy showing 80% local controls. Second malignancies is a problem. If you can reduce the dose of radiation, you can reduce the incidence of second malignancies if you reduce less than 45 to 48 grays. I'll skip the slide. Second malignancy is a problem, but it is pretty similar to the second malignancy rates that you would see with chemotherapy. So to conclude, radiation therapy definitely contributes significantly to the local control of Ewing sarcoma. Currently, almost 30 to 40% of patients would require radiation therapy in some form. Escalated doses of radiation seems to improve outcomes. Lung bath and high precision radiation therapy improves local control and avoids toxicity. Second malignancies is an issue, but it is about 5 to 7% at 20 to 25 years. So thank you very much, and I'll be happy to take questions.
Thank you, Dr. Laskar. We now go to the third lecture. That will be by Dr. Girish Chinnaswamy on optimal chemotherapy in relapsed Ewing sarcoma. Dr. Chinnaswamy, please.
Yeah. Thank you, Dr. Huku. Can I get my slides on, please?
As we are sharing the slide, Laskar sir, thank you. There are 2-3 questions in the chat box. I would request you to answer and give your comments in the chat box.
Sure.
Dr. Laskar. Dr. Girish, you can proceed with your talk.
Yeah, I think Pooja, Tarun are putting my slides up.
Yeah. Yes.
Yeah. Thank you, Randeep, and for all organizers. So I will be now speaking in the next few minutes about optimal chemotherapy strategy for relapsed Ewing sarcoma. And at the outset, I would like to say this is a presentation which was jointly done by our trainee, Dr. Kalashekar as well, who has done a lot of work on relapsed Ewing sarcoma, and some of the slides are from him. Next slide, please. As you all know, after completion of primary Ewing sarcoma therapy, a majority of the localized disease do well, and about 25% of them will relapse. Whereas it's the other way around in the metastatic disease, about 50 to 80% of the cases will relapse. Either they may have a combination of, they may have a local relapse or a metastatic relapse, or many times what you see is a combination of local plus metastatic disease. Next slide, please. So what we did not know for many years is how do we actually approach a relapse of Ewing sarcoma. The earliest publications actually came from the Rizzoli group, who actually treated Ewing sarcoma with various combination of chemotherapy, including some only receiving local treatment and some only receiving only chemotherapy without local treatment. And what they came to the conclusion was that if you gave only chemotherapy, the outcome was extremely poor. And if you did local treatment, some of them did survive. But what was most optimal was to do a combination of local treatment and systemic therapy. However, in their studies, which was from public cases which were included from 1970s to 1990s, the 5-year survival was very suboptimal at about 10 to 20%. And in primary progressive Ewing sarcoma, the outcome was really dismal. Next slide, please. So what the studies have also shown that the prognostic factors of post-relapse of Ewing sarcoma are now much more better defined. So this study is from the Children's Oncology Group, where the patients who were treated on the INT 0091 study and the patients who relapsed after that treatment regimen were studied to see what actually made an impact. And what was found was the disease-free interval is the single most important prognostic factor in relapsed Ewing's. So that is, if any patient who had actually 2 years from the time of diagnosis, was more than 2 years from the time of diagnosis of the primary tumor and then relapsed, they had a much better outcome than patients who relapsed within 24 months from the time of diagnosis. And that outcome varied for about 30% for the 5-year overall survival for patients who had more than 2 years disease-free interval versus only 7% for patients who had less than 24 months disease-free interval from the time of primary diagnosis. So this was a very significant prognostic factor. Next slide. The studies also identified both from the Children's Oncology Group as well as from Stahl-M, which is from the German group, that the German group had actually 700 cases of recurrent Ewing sarcoma done over various studies, the ICES and the CES studies. And they also identified, along with this Children's Oncology Group, that if you have an isolated local recurrence, they tend to fare better. And they saw that if you had an isolated local recurrence, which was treated with a combination of chemotherapy and local treatment, you had a survival of 5-year survival of about 24%. Compared to those who had systemic metastasis. When they mean systemic metastasis, the majority of them were pulmonary metastasis. And when they had a pulmonary mets, they had about 12 to 20%. But when you had a combined local and distant relapse, they had the worst outcomes. That means if you had a combination of a local plus pulmonary mets or a local plus bone or bone marrow mets, then they had the worst outcomes. And there the outcome, whatever the time period from the time of relapse, was less than 5%. So these studies, both these studies clearly showed that time to relapse was important, as well as the type of relapse which occurred, whether it's local or combined or only metastatic relapse, had a significant impact as well. Next slide, please. There were also other prognostic factors which were identified. One was the younger age at relapse. They actually tended to do better, as well as if you did not have a very high disease burden or turnover, which was reflected by lactate dehydrogenase, they tended to do slightly better as well. Next slide. So, however, at this time, there was no standard treatment strategy for relapsed Ewing sarcoma, and everybody had customized the treatment based on institutional or individualized care. Next slide. So, generally, the principle which was followed for management of relapsed Ewing sarcoma involved giving a combination of multi-agent salvage chemotherapy and local control, which depended on a case-to-case, whether a surgery or RT or a combination of both, and also control of the metastatic sites most of the time, which was done by radiotherapy. And this was the preferred treatment approach or the basic principle how relapsed Ewing's was being treated. Next slide. And these were all the conventional chemotherapy regimens which were used for relapsed Ewing sarcoma from the 1990s onwards. The most commonest one or the best studied combination was irinotecan and temozolomide. The other one was topotecan and cyclophosphamide. The rest being high-dose ifosfamide, gemcitabine, docetaxel, and ICE chemotherapy, which was a combination of platinum, ifosfamide, and etoposide. Next slide. But if you look at what were the outcomes with these various chemotherapy regimens, you can see that temozolomide and irinotecan, which was best studied, had the best outcome. And the response rate was about 47% over various studies. And all these were cumulative patients over multiple studies, which are all single institution, most of them retrospective studies, which showed 166 patients. The second best combination to use was cyclophosphamide topotecan or ifosfamide, which both had in the low 30s outcomes or response rate which was seen, followed by gemcitabine docetaxel and the other ones. Next slide. Yeah, next slide. But what was seen was the toxicity of this treatment was very different between different regimens. So myelosuppression was high with high dose ifosfamide or with the topotecan cyclophosphamide. In fact, with the topotecan cyclophosphamide, most of them not only get significant neutropenia, but also even go on to get mucositis as well. The other problem was renal insufficiency and encephalopathy, which was seen with high dose ifosfamide. Neuropathy was the main problem in gemcitabine docetaxel, and diarrhea and abdominal pain was for irinotecan and temozolomide. But all the regimes which were used in relapsed Ewing's were outpatient based, except the high dose chemotherapy, high dose ifosfamide, which actually made an admission mandatory for about 5 days. So there was not much to choose between topocyclo, high dose ifosfamide, and irinotecan temozolomide in terms of the outcomes. But the inpatient admission, the cost of treatment, and the toxicity profile was very different between the three. Next slide. So in children, there were actually two studies which were published in the early 2000. One was using the topotecan and cyclophosphamide, which was published from the German group. And they showed that the 1 year overall survival was 61%, and 19 patients had actually achieved CR just with chemotherapy out of 54. And a similar study was also published from the Memorial Sloan Kettering, again in children. And again, they showed that in 20 patients, what they saw, the overall response rate was 63%. And the time to progression was better when there was a long TFI. So these were the regimes which kind of were pretty much being used globally. Next slide. But as we were designing, looking into our treatment at Tata Memorial Hospital, so we realized that giving just 6 to 8 cycles of topotecan cyclophosphamide caused significant myelosuppression and mucositis. And the irinotecan temozolomide was a 2 week out of 3 week coming to the hospital, which was 2 weeks continuously the child came to the hospital. And at the same time, we kept the child in a longer time, although the side effect of myelosuppression was much less. So we thought whether it was, since both of them had relatively equal outcomes, whether we could actually use a hybrid protocol of using irinotecan and topotecan. Both of them are topoisomerase 1 inhibitors. And the mechanisms of resistance and spectrum of activity is different. And we felt that since the progression with one drug does not preclude response to the other, that this may actually get a slightly better outcome than just using irinotecan or topotecan alone in each patient. Next slide. So we designed the team. Yeah.
Second left.
Yeah. So we designed the team.
30 seconds.
So can we go to the next slide fully? Yeah. Next slide. Yeah. So this was the induction regimen hybrid. What we used initially a combination of VTC and irinotecan temozolomide given in couplets, and we gave anywhere between 8 to 12 cycles. Next slide. Next slide. And this was what the outcome which was published just the last month by Kailash Ekar and Tushar Vora. Next slide. And what we saw was the hybrid regimen had an overall response rate of 75%, which was much better than what was published with individual regimes. And the toxicity is listed below, with neutropenia being seen with the topotecan arm. Next slide. And these were the outcomes on the 47 patients what we saw. The 4-year event-free survival was 28%. And the overall survival of 37%. Next slide. And looking at the prognostic factors, again, children who had a long DFI, more than 2 years, tended to do much better. And we saw a trend towards the adults and young adults having a better outcome on univariate analysis, although on multivariate, it was only the DFI which mattered. Next slide. So this is the last slide, which actually shows that there is an ongoing trial looking at which is the best regimen for recurrent Ewing sarcoma. And this is looking at all the 4 regimens which we discussed. But next slide. And this is actually going to complete recruitment only in 2025. It's a multi-arm trial which is adaptive design. And hopefully we'll get an answer which is the best regimen to use. Next slide. So next slide. So to conclude, that it is critical to actually risk stratify relapsed Ewing sarcoma and plan for curative treatment in a subset of them whom we think have a reasonably good prognosis. You can either use vincristine, topocyclo, or irinotecan temozolomide, or a combination of them as are the most widely used. Hybrid regimen, which we showed, has given encouraging outcomes with acceptable toxicity, and the role of ABMT is not yet clear at all and should not be routinely recommended. So I think that's my last slide, and happy to take any questions on chat. That's done. It's done. It's finished. Actually. Thanks.
What happened to his voice?
So I finished, Dr. Rupu.
Okay. So thank you very much. We have now heard three speakers, a surgeon, a radiation oncologist, and a medical oncologist. Now to summarize, all the three talks in another few minutes. We all know that more than half the patients will have a synchronous or metachronous lung metastasis. With aggressive chemotherapy, we have been able to push the disease-free survival rates to quite higher levels in Ewing sarcoma. We all know that the negative prognostic factor is lung metastasis, and metastatectomy is the best predictor of survival. The most important thing is proper selection of the patients who have a potential to derive maximum benefit without significant complications that may require a prolonged rehab. If you select your patients properly and time your surgery properly, that will make a difference between good and bad results. It is being used quite frequently across these cases. Now, as Dr. Laskar said, in radiotherapy has been used in Ewing sarcoma for many, many years, decades rather. When we were students in late 70s, we were very happy to get Ewing sarcoma because it was a sensitive tumor and we could treat it very well. But these patients failed because of the metastatic disease, although we were able to maintain local control. Lung baths were also given very effectively those days. Now with good chemotherapy, we have been able to control the metastatic disease, but the role of radiotherapy has come down to local control, although surgery still scores over radiotherapy because of a better control rate. Unfortunately, there is no head-to-head comparison between radiotherapy and surgery because of various biases. But still, radiotherapy alone and in combination is used in about two-thirds of the patients of Ewing sarcoma with good results. The tumor of childhood, we have to be very, very careful about long-term morbidity, and therefore the volume covered, a modern radiotherapy technique, and the doses are very, very important. These tumors will benefit with the use of protons and carbon ions because of the
Total duration is 25 minutes.
Only a 5 into 7 centimeters. Go straight to the case that will allow us to have a realistic panel discussion. This is about a 16-year-old boy who had a pain and swelling in the right lower thigh since September 2018. He presented to us sometime in early 2019. The biopsy scar was present over the lower middle side of thigh.
So my observation is less. It is
going better.
Functionally acceptable methods, largely. Good evening, everyone, and thank you, organizers, for giving me the opportunity to debate over an issue which will radiotherapy.
Yes.
Organizers for most of my work, very equipoised evidence and and saying that surgery, except for its morbidity, it has good or equivalent or maybe better outcomes. But I will show you in detail how I feel and how most of the surgeons globally feels. We all know that pelvic tumors are complex situations with large disease volume, which usually present at a higher stage, and they are definitely surgically challenging with limited reconstruction options. And when we talk specifically about Ewing sarcomas, we all know that local control is sandwiched between induction and maintenance chemotherapy. And to achieve the best local control, we have mainly three modalities, which encompasses radiotherapy, exclusive surgery, and surgery in addition to radiotherapy. And we'll see what evidence says what works the best. If you think logically without any evidence, and we try to see what kind of option you would like to offer your patient, or if you are patient you would like to choose, if you have such a high malignant disease, would you want an option where you will still have to retain the disease bone in your body? Maybe not. Would you like to have an option which has a higher chance of local failure? Maybe not. Would you like to have an option which gives a lot of complications like radiation injury and growth arrest to adjacent plates, or maybe give long-term complication like fibrosis? Maybe not. And obviously, as Anjali also mentioned about various second cancers which may or may not be contributed to chemotherapy alone, and we can debate that further. And definitely you want an option which is shorter in duration and quickly completed. And just by looking at logical sense, it seems that surgery is definitely a better option than radiotherapy. But then I thought, let's not just talk about logical stuff in this evidence-based meeting, and let me back it up with evidence. And then I started searching a lot of evidence about it. And the first evidence which I got was from my dear friend, Dr. Siddharth Laskar, who is one of the most important and prominent sarcoma radiation oncologist, who long back said in 2008 itself, and he agreed that surgery offers better local controls, and better local controls are equivalent to better survivals in Ewing sarcoma. And once I searched that, I actually thought that that's the end of the debate, and I'll just put a thank you slide, and I'll just say that surgery offers a better local control compared to radiotherapy alone in pelvic sarcomas. But then, I know we have a lot of friends around, and they will start thinking that maybe I'm just biased with my friend Dr. Laskar, and as I always listen to him, I should not just stop, but I should look at more literature and try to back up what he already said. And then I thought, let's look at studies. And what I realized that what Dr. Laskar was saying in 2008 was actually Sloan Kettering had said in 1980s as well, when most of these Ewing sarcomas were treated with chemotherapy and radiotherapy. And when one of the first studies which they did, and they found that surgery gives fantastic results as compared to radiotherapy, and having a negative margin gives you fantastic results, and hence everybody started propagating surgery for these tumors. 6 years later, another center in United States came up with 140 patients, big series, and again showed the same thing as you can see here, where radiation only has the worst outcome, and surgery along with chemotherapy, with or without radiation, has the best outcome. So again, surgery comes as winner in all these age-old publications. 2 years later after that, again from Mass General Boston and the Boston University, Howard University, again came another paper which clearly showed undoubtedly that if you have surgery as the option to remove the Ewing sarcomas, it works best along with chemotherapy. Anyways, I thought this was in general very old literature, and let me look at some literature which is specific to Ewing's pelvis. Way back, almost about 21 years back, we have this paper which from the French group, which exclusively talks about pelvic Ewing sarcoma. Again, you can see Kaplan-Meier curve showing a statistical difference between the survival of the patients who were treated with surgery with or without radiotherapy as compared to only radiotherapy and chemotherapy. Again, substantiating or supporting the fact that even in pelvic cases, surgery does better. We go further down south in Europe to Italy, one of the biggest group from Rizzoli, an entire Italian group in 2007 came up with this landmark publication, which again showed that patients treated with surgery with or without radiation therapy had a better local control, 82.6% versus 66.7%, and 5-year EFS was significantly better, and they've again proved the same fact. Then we have the trial from Mark Scarborough and group from University of Florida, and they have this 30-year experience, and they looked not just the overall survival, they looked at the local control, they looked at the absolute survival, they looked at the cause-specific survival, and again the same findings back and back again, that surgery does better than radiotherapy. We all know the German surgeon and entire German group is a very cohesive group, and they are very aggressive. German group in 2011 again showed that the patients who are treated with surgery does much better. Let's look at our Indian-owned data. In 2012, we looked at the Ewing sarcoma and also look at the last author in this publication, Dr. Siddharth Laskar, along with me and Dr. Puri, which again stated that we have fantastic local controls with overall survival of 72% at 5 years. And maybe Anjali can mark that and maybe compare with various RT trials which has shown this outcome. And I know Dr. Laskar has a great trial coming up, and we are really looking forward to those results. But I think these results are equally good to show that surgery does much better. And why only us? You look at the Canadian group, which again showed in this meta-analysis that surgery does better. So again, we have a lot of literature, and I thought not just pelvis, look at other slides, and you have n number of literature again showing that surgery does better from Rizzoli. Again, from COG group, we all know 465 patients again showed that patients who are treated with surgery do much better. Again, a COG paper on all Ewing sarcoma patients, 965 patients, again substantiating the same. So I think there's enough literature to support that, and I think I can just go on and on. But we also know, I know Anjali talked about surgery being very morbid and complex and have various complications, but we also know that radiotherapy is also associated with short-term and long-term complications. And though we can't compare apples and oranges, but there is enough literature to state that after radiotherapy, these patients may undergo fracture, which may never ever heal, and these patients may require amputations for those surgeries and have various associated complications, which are very well documented in international trials as well. So does that mean...
Ashish, please conclude. Ashish, please conclude, please.
Okay, so I think they have a good role in tumors which are in the sacrum, which involves various organs in the pelvis where morbidity is extremely high. And adjuvant therapy is must in Ewing sarcoma, and we have conventional and additional factors which help us to decide that, and hence we conclude that even if with surgery we have improved outcomes, and with the help of various newer techniques we can decrease the morbidity of the surgery, we can have better outcomes with just doing pseudoarthrosis, which can obviate the need of metallic prosthesis and can remove all the complications. And talking about function, this is a 12-year function of simple mesh plasty. I don't think so this is any way inferior than radiotherapy functions where this kid is doing almost everything after 12 years and is a really proud sportsman. And just to support, we have various guidelines like doing the same, and ESMO guidelines as well. Thank you very much. I think I put my case, and I think surgery works good, and radiotherapy definitely helps in treating at specific indications and as an adjuvant therapy. Thank you.
Anjali, would you like to have a rebuttal?
Sure, sir. Do I have a minute?
Yes,
for
you
that?
have. You have 1 minute. Yes.
Definitely.
Include that.
Put it
So I think over to Sameer
It's on histology.
to cover this. Yeah, thank you.
Thank you, sir, for the opportunity. So I'll start with histology-tailored therapy in advanced sarcomas. So right now, everything depends on histology. It's not soft tissue sarcoma. It's very variegated and heterogeneous. I'll come to all these subtypes. So my topic will be covered in these subheadings. This is the figure that represents the newer therapies, pazopanib, trabectedin, and eribulin. Pazopanib acts on VGFR receptors and PDGFR receptors. So this is the registration trial for pazopanib. And if you can see, it was a placebo-controlled trial in advanced soft tissue sarcomas, non-adipocytic, that is non-liposarcomatous. Primary endpoint was progression-free survival. There was 3-month progression-free survival benefit and hazard ratio was 0.31. Based upon this, it was FDA approved in 2012. The most common toxicities were fatigue, hypertension, diarrhea, the percentage of which were very less, like it was very well-tolerated drug. Regarding Indian patients, the most common toxicity we present in ESMO Asia was hand-foot skin reaction. So the most common was hand-foot skin reaction, and median PFS in our patients in updated analysis with 66 patients was 5 months, which is as good as 4 months or 3 point something months in the original study. If you see, majority of our patients received 400 mg because 600 mg was not tolerable, or we could not escalate to 800 mg. So probably because these doses are weight-based, we need to rethink about the doses. Regarding trabectedin, which is C derivative derived from Actinidia tabinata and now synthetically derived, this was tried in L sarcomas, that is liposarcomas and leiomyosarcomas. Those who have progressed on previous anthracycline containing regimen. This time, the comparator was dacarbazine, unlike pazopanib trial, because that was a previous trial in 2012, this was in 2015. Primary endpoint was overall survival. Again, 2 point something months benefit was there, it was 2.8 months, and it was FDA approved based upon it. And then we wrote to Journal of Clinical Oncology that probably the bar for 2 point something months and FDA approval based upon PFS, no quality of life done. But now we have simultaneously, at that time also, it was also seen to be beneficial in another subtype of sarcomas called translocation-related sarcomas. Synovial sarcoma, ASPS, clear cell sarcoma, DFSP, etc. It was compared with best supportive care in patients who have almost progressed on everything. And as you can see, it improved PFS dramatically. However, this is not FDA approved for translocation-related sarcomas. So this is our patients. We had 20 patients till 2019. Now we have 30 patients. Most common subtype was leiomyosarcoma. And as you can see, the PFS, median PFS was 4.5 months. So median PFS looks modest, but if you go into details, then 6 out of 20 patients did well for more than 1 year. Toxicity was just in coherence with previous studies. And now there is a paper by Dr. Shofsky which says that we can give ambulatory infusion by elastomeric pump. And last 100 infusions we have given by elastomeric pump also. This is a picture of our patient who is on dosifuser pump. So this is a patient of gastric leiomyosarcoma who had excellent response on pazopanib, had progressive disease. We started on trabectedin, first CT's baseline, second after 3 cycles, and third after 17 cycles. So even after 1 year, patient was responding very well, which is something unprecedented in sarcomas. Another subgroup analysis for trabectedin came with only 5 patients, which showed that it is very active in extraskeletal mesenchymal chondrosarcoma and myxoid chondrosarcoma. So we tried in mesenchymal chondrosarcoma after trying Ewings-like therapy. And as you can see, we had stable disease with clinical benefit for almost 1 year. Again, it was few years back, it was not seen with any of the drug. So we have newer therapies with quite hope now. So, but there are unlimited histologies. Propranolol in angiosarcomas, or this is a patient with infantile solid fibrous tumor, post-propranolol based regimen, almost complete response. And he was deemed palliative at some time, but now he's a survivor. Similarly, this patient, angiosarcoma, propranolol plus methotrexate plus vinblastine, almost 1 year, 1.5 years with complete remission. Again, superb results. This is our patient with DFSP, which is extremely rare type of sarcoma, almost 1% of all sarcomas. And metastatic, in that too in metastatic setting, we used imatinib. Response rate was 71%. So, and it is chemorefractory. Had we know, like if we wouldn't have the expert histopathology with DFSP, we wouldn't be getting this kind of results. And tyrosine kinase inhibitor in ASPS, a patient who had 2 years response. This is IMFT, metastatic, complete response after quizartinib. And this is one of the nice paper that we have submitted to clinical sarcoma research just now. Metastatic chordoma, for which outcome is so dismal, but now erlotinib has been seen to be good in this disease. As you can see, this is axillary node, this is abdominal disease, and after erlotinib, there is almost complete response. And this patient had almost 1 year of disease free now. So probably if I keep on telling about histologies, it is unlimited. What about immunotherapy, the talk of the town? So we see out of SARC-028 trial, we saw that it is effective in undifferentiated pleomorphic sarcoma, and it is also effective in ASPS. So we have given immunotherapy to 9 patients till now, of which 3 patients have derived good clinical benefit. I'll come to it. This is our paper in clinical sarcoma research. Recently, we tried the combination of pembrolizumab and pazopanib, post-progression on olaratumab-based regimen and gemcitabine and docetaxel. PD-L1 was 25%. And as you can see, January 2019, patient was baseline. After gemdosi, May 2019, patient is still in near CR. So almost more than 1 year. Again, something which has not been seen in undifferentiated pleomorphic sarcoma. This is a patient of young lady with ASPS, extensive mets, lung, mediastinum, pelvis, bones. And as you can see, there is the lung metastasis is not visible after 22 cycles of nivolumab. She came to OPD yesterday and she was perfectly all right. So probably we have immunotherapy also, and it is also going to stay, but we need to see which kind of patients will be benefited by immunotherapy. So I'll thank all of my colleagues who are helping me in doing this work and making my presentation. And again, I will highlight this slide that now it's no more limited to only soft tissue sarcoma. It is so heterogeneous that we need to think about every sarcoma, and it needs a sarcoma-specific pathologist. Thank you.
Thank you, Dr. Rastogi. And now I invite Professor Siddharth Laskar from Tata Memorial Hospital, Mumbai. He needs no introduction to speak on evolving indications of radiation therapy in soft tissue sarcomas today. Dr. Laskar, you have 10 minutes.
Thank you. Samir, you have to stop sharing the screen. Thank you. So thank you very much. Thank you for staying late. I'll quickly go through the evolving evidence of radiation therapy in soft tissue sarcoma today. I'll try to touch upon some of the issues that we see in our clinics every day. So this was very aptly mentioned by Bill Henneking, the surgical oncologist all of you know. And he said that the value of adjuvant radiation therapy is in extending the margin of limb salvage surgery that otherwise has a high risk of recurrence. And this is absolutely true when we today. So is limb conservation feasible, and what is the evidence? And we will move from here. So this is a randomized trial, very unusual, of amputation versus limb sparing surgery and radiation to a dose of 50 gray followed by a boost, along with chemotherapy. And the outcomes show that local recurrence, obviously, in the amputation arm was better, but there was no difference in overall survival. So this was the basis for, considering limb-preserving treatment in soft tissue sarcomas. When you look at the role of radiation in limb preservation, this was another randomized controlled trial published by the NCI, where patients had limb-sparing surgery alone versus limb-sparing surgery and external radiation therapy. The outcomes showed that the patients who received adjuvant radiation therapy did better than the ones who had limb-sparing surgery alone. So what we know from this study is that addition of radiation therapy is required when you're doing organ preservation. Now, the next important thing is timing of radiation therapy. Which one is better, pre-op versus post-operative? All of us know there are certain advantages and disadvantages of pre-operative versus post-operative. When you do pre-op, theoretically the fields are smaller, probably lesser radiation dose required. It eliminates the delay between surgery and radiotherapy. And the other advantage is post-operative, you can actually tailor the portals. It eliminates the delay in resection of the primary tumor, which is supposed to be radio resistant, and possibly eliminates RT in the low risk or low grade tumors. So these are the basic theoretical differences between pre and post-operative radiotherapy. So do we have a trial looking at pre versus post-operative? Again, most of us know about this trial from the Canadian group, the SR2, where they randomized between pre- and post-operative radiation therapy in soft tissue sarcomas. So what was found is that the big difference was in the wound complication rates. It was almost double in the pre-operative group compared to the post-operative. And there was increased fibrosis. But the good thing about pre-operative radiation was that the overall survival seemed to be statistically significantly better in the pre-operative RT group. So based on this, many of the centers in the West have actually moved to pre-operative radiation therapy. In our center, we prefer to do post-operative because of the brachy that we do for our patients. So based on the study, they looked at a way by which they could reduce the toxicity. So they would do this special IMRT technique where they would reduce the dose to the possible site of surgical scar. And by doing that, again, Brian O'Sullivan and his group compared it with the pre-op versus post-op RT trial, and they showed that they were able to reduce the complications of pre-op radiation therapy by using a IMRT technique to spare the scar site of high-dose radiation. So there are ways by which you could reduce the complications of pre-op RT. So what do we really do by doing 3D CRT or IMRT? We are able to spare the normal structures better. And by sparing the normal structures better, you are reducing the dose to structures like the femur, the skin, the soft tissue. And by doing that, is there any difference in the outcomes? So this was a study, again, from MSKCC, where they looked at conventional RT versus IMRT. And what they found was that the disease controls were slightly better in the conventional RT, but the complications were actually better in the IMRT arm. So IMRT definitely helps you reduce complications. And these are two other studies where we did discuss about fractures in sarcomas when you give high-dose radiation. And this is clearly a relationship between the dose of radiation and the volume of bone that you treat. The smaller the volume, the lesser the dose, the lesser is the complication in the form of fractures. What about target volumes? The conventional way used to be that high-grade tumors, you have to do a margin of about 5 centimeters beyond the tumor. So that really increased the volume to a large extent. But there are new studies looking at reducing the volume, the target volume, or the CTV in the radiation parlance. And in the Vortex trial, they reduced the margin from 5 centimeter to 2 centimeter. And what they showed in this abstract is that the local controls are more or less same. But this study still needs to be published in the full form to show that really reduction from 5 centimeter to 2 centimeter is possible. So there is volume that is reducing to 2 centimeters now. Now, another thing that we keep discussing in our clinics is the interval between surgery and adjuvant radiation therapy. Is there an impact really? So if this has come from the French group, just to summarize, they looked at the outcomes of delay in radiation therapy, and what they reported finally is that there is no significant impact of time interval between surgery and radiation therapy. So if you're thinking that a delay, you may be able to avoid radiation. So I would suggest that if it is about within 2 to 3 months, possibly you should still go ahead and give radiation therapy. What about flaps? Sometimes we have plastic reconstruction, and many a times we discuss whether the complication rates would increase if you're doing external RT after a plastic reconstruction and whether you should avoid radiation. So at least from this experience, which is relatively large, it is seen that the flaps do not really increase the risk of post-op complications in soft tissue sarcomas after radiation. Now, what happens if you sometimes have a surgical margin that is positive, or if you've done pre-operative radiation therapy and you find your margin is positive? So what do you do? This is a recent publication that has come last year, and what they concluded was that patients who have a surgical margin which is positive, where you have R1 resection, there is benefit of escalating the dose of radiation to close to 70 gray. So what they found, and even in patients who have had pre-op radiation therapy, the new evidence that is coming in says that adding a boost dose of radiation to the positive margin actually improves overall survival. So this is new data that is coming in regarding patients with positive margins after surgery. What about brachy? I have no talk without having brachy. Brachy is a very effective modality. Even in limb sparing, it reduces the volume of normal tissue and does not compromise on disease control. It is effective both in low and high-grade soft tissue sarcomas. We don't have a head-on randomized trial comparing brachy and IMRT, but this is from my friend Khalid Alektiar from MSKCC, where he reported his IMRT outcomes and compared with brachy. In terms of disease control, IMRT seemed to be doing better, but these were more recently done. But in terms of wound complications, brachy seemed to be doing better than IMRT. We have our own results here, which is very high control rates with with brachytherapy, and our complications with brachytherapy is much, much superior compared to brachy and external radiation. Our long-term outcomes in our children, 10-year local controls of 83% with brachytherapy. So brachytherapy actually works very, very well, both in adults and children. So what about metastatic disease? This is my last slide. Patients with pulmonary metastasis, now with the modern technology that we have, this is a nice article which is currently in press. It is supposed to be published in November 2020. So they looked at the comparison of SBRT for treatable lung metastasis from soft tissue sarcoma compared to metastatectomy. And what they found was, in terms of what the authors wrote here, was that the local treatment for pulmonary metastasis with SBRT compared with surgery was associated with a lower cumulative overall death rate. And that may be because the complications were more in the patients who had surgery. So what it broadly tells us is that with the new technologies that we have in our hand, we would possibly be able to have good outcomes even in patients with pulmonary metastasis. So to conclude, radiation therapy forms an important component of the multimodality treatment of soft tissue sarcomas. Both external RT and brachytherapy have good outcomes. We don't have head-on comparison of brachy and external RT, but they seem to have similar local control rates. And there is more and more evidence that we could possibly use SBRT for pulmonary metastasis with a curative intent. And there is new data that is not still available, I can tell you, that people are looking at reducing the dose of external beam radiation from the conventional 60 gray to 50 gray. So very soon, the volumes of radiation will become smaller, and also the dose of radiation will also get lesser and lesser. So thank you very much for your attention, and I hope I was able to stick to the time.
Yeah, thank you, Dr. Laskar, for finishing in time. And
whatever you treat, the disease is killer. So I'll be speaking on what is oligometastatic soft tissue sarcoma and how do you manage it. The flow is what is the historical context, what is the biology of oligometastatic disease, and is there any evidence, and how do you treat this oligometastatic disease by way of surgery, radiation, intervention, radiology, or by chemotherapy. So the paradigm to understand oligometastatic disease is you have to understand the paradigm of metastatic disease always was that whenever someone had a metastatic disease, it was always a sentence of death. It would just mean to say that whatever you treat, the disease is already widespread and there's nothing more that you could do. all that went around to change with the spectrum hypothesis that came about in 1994 with breast cancer, which basically said that all cancer is a spectrum. At one end of the spectrum, you have that low volume, non-metastatic, low-grade disease. At the other end of the spectrum, you have the fulminant tumor with high grade, which is metastatic everywhere. And in between is a spectrum, you have a wide variety of metastatic, non-metastatic, and a wide range of biological aggressiveness. So that's when the concept of oligometastasis really came about in 1995. It was a novel concept which meant to say that there was a small subset of patients who had limited site of disease. Those limited site, what is oligo? That is a very not well defined for soft tissue sarcomas. It could mean anything between 1 to 3 or 1 to 5. That they had limited metastatic potential, and that the metastatic sites, once it spread, would not spread further. So by removing the primary as well as the metastasis, you could offer long-term survival to these patients. So that's when the concept of metastasis-directed therapy also came about, which means to say that it is directed towards the metastasis, not just by way of systemic therapy, but by way of local therapy where you remove the metastasis either with radiation or with chemotherapy. And then there are a few other terms that we need to know. What is synchronous oligometastatic disease? The tumor presents the primary and the metastasis presents at the same time. What is metachronous? The metachronous is present after a time when the primary has been treated. What is that time? That's arbitrary, that is not well defined. A lot of people take it as 6 months, a few people take it as 1 year as well. What is oligo-recurrent? Which means to say that you've treated the primary, but it has recurred at oligo sites. Oligo is 1 to 3 sites. Now, oligo-recurrent and oligometastatic metachronous can be synonymous. And there is also this term of oligo-progressive, which means to say that there is metastatic disease to begin with. The patient is being treated with systemic therapy. Everything else is in remission except 1 or 2 sites which are increasing in size. So that is oligo-progressive disease. So the earliest data for treatment of this oligometastatic disease really came about by CNS tumors both in the brain and the spine, where they said that by treating these patients you could improve survival and you could improve functional outcomes as well. The patients were mobile, they were not confined to bed, their bowel, bladder and mobility was well preserved. And you also had data from non-randomized controlled trials, the IRLM, the International Registry of Lung Metastasis, which had all kinds of metastasis, all kinds of primaries which had lung metastasis. But important to note that 42% of them were sarcomas, wherein you had long-term survival. Even 15-year survival was up to 22% of these patients with metastasis. And if you had a solitary metastasis to the lung, you had 10-year survival, which was approaching 34%. How do you treat this metastasis, whether it is surgery or with the SBRT? We'll come to that later. And not only the treatment in terms of survival, you also have other benefits from treating this metastasis, which is you could delay systemic therapy. That is, you could keep it in reserve at a point in time when the patient had the metastasis. You also have the abscopal effect, wherein treatment of one site of the primary has a beneficial effect, wherein the other sites of metastasis just completely disappear. That's not been well reported in sarcomas, but is a well-known effect for treatment in metastasis. The problems with this is these are all non-controlled, single-arm observational studies, and really whether the benefit of ablative therapy really is there or not is a little bit of a concern. There is also a few biases that are there. One is the immortal time bias, which means to say that the patients before are included, but in the cohort studies they do not have time to develop the event, which is death. There is also the all or none criteria, which means to say that you've treated all patients with oligometastatic disease and all of them live. But that might be a fallacy, because there might be a small subset of these patients where even if you don't treat them, might go on to live for a long time, have long-term survival. Again, without clear data, it adds to the morbidity, it adds to cost, may also increase mortality. There is unrealistic expectations from the patient side that they'll be completely cured of disease, which might not be true. So it all boils down to proper case selection. There is also the tip of the iceberg, which means to say that there might be a subset of patients where you see these oligometastatic sites at a few places, but they may only be the tip. Once you remove them, there is fulminant metastasis within a very short period of time, because there would have been micrometastasis elsewhere. So you need better biomarkers, which could be either circulating tumor cells or microRNA to find out. Again, there is heterogeneity in the tumor across tumors. Not all soft tissue sarcomas are equally sensitive to chemotherapy or histologically directed therapy, as Samir very well told us. And even within the same tumor, there might be tumor heterogeneity in the metastasis, the primary or the metastasis, one might respond more than the other. And then there's also a lot of controversy on the timing of local therapy, systemic therapy. Do you do both at the same time? The local, the metastasis. When do you get in systemic therapy? There are a lot of unanswered questions in this. So also always remember that what is a solitary pulmonary nodule? I just brought it in here to say that a solitary pulmonary nodule is something that is less than 3 centimeters in diameter, usually surrounded by lung parenchyma. You can get an SPN after treatment of the primary at a point in time. All of them may not be metastasis. It can be anything from benign to malignant, inflammatory, or it can be something else also. You need to evaluate if it's a solitary metastasis in the lung. You need to actually conclusively prove that it's not a prove that it is a metastasis before you treat it. So coming to pulmonary metastasectomy, again, the International Registry for Lung Metastasis, I've already told you have 5-year, 10-year, and even 15-year survival. There were 5,200 patients. Just remember this number. We'll come to this a little later. There were 18 institutions across in 94, 95. Again, there is also additional evidence from the EORTC trial, which is 255 patients across institutions, which said that if you treat pulmonary metastasectomy with curative intent, you have 5-year overall survival up to 40%. And 3-year survival up to 54%. There is again the MD Anderson experience, 234 patients here. Again, just you can forget the group C1 and C2. Just look at group A, B1 and B2. They stratified patients according to only pulmonary metastasectomy, either synchronous or treatable extrapulmonary metastasectomy, which were treated previously, or non-surgical treatment right now, and prior extrapulmonary metastasis. So B2 were untreatable or non-operable. A and B1 were treatable. So if you look at the survival data, A and B1, there was no difference in the survival between A and B1. That is, if you treated the pulmonary metastasis with curative intent, there was no difference in survival. Whereas in B2, which was non-treatable, between A and B1 and B2, there was a significant difference in inferior survival for B2, which just meant to say that inoperable pulmonary metastasis, even though was metastatic disease, had inferior survival, and operable pulmonary metastasis, even in the presence of extrapulmonary metastasis, which was treated, had better survival. The prognostic factors for increased survival were if you could operate more number of times, it just means to say that the biology was better, more than 12 months mean time between the pulmonary recurrences, more than 24 months time between the extrathoracic recurrences, again indolent biology, everything boils down to biology, and the prognostic factors for decreased survival were multiple pulmonary metastasis group and group B2 patients. So it all, like I said, it all boils down to patient selection. Yeah, I'm just finishing. So the patient selection is you should have presence of a control or controllable primary, completely resectable metastatic disease, absence of multivisceral disease, and medically fit. And the prognostic factors, like I said, you should achieve R0 resection, limited number of nodules, long disease-free survival, small tumor size, favorable histology, and low grade. Surgical approach can be either thoracoscopy, thoracotomy, I think is very well already explained by one of the previous speakers. And recurrent metastasis, again, this 5,200 patients, of those 1,042 underwent repeat metastasectomy. Even in these patients, you found out that the 5 and 10-year-old overall survival was about 30% of them had 10-year survival. Again, the prognostic factors were high-grade histology, bigger size, and more number of patients. Radiation therapy in metastatic sarcomas, I just don't need to go there. I think Dr. Lashkar nailed it. He said that SBRT, you can give it, usually traditionally was given for patients who are inoperable at presentation, but Dr. Lashkar has nothing more to add to that. It can be used as an adjunct or as a substitute for pulmonary resections. Intervention radiology, again, last slide. You can have ablative techniques where this is usually used for patients who are not candidates for surgery, wherein the volume of disease is by, you can have either ablative techniques which are either hyperthermia or cryotherapy, or you can have embolization or chemoembolization. Again, the important thing here is to remember are the local recurrence rates. For RFA, which is the most studied, you have local recurrence rates of 0 to 15%, which means to say that 85% of them were controlled very well. The long-term efficacy for RFA was 1-year control was 92% and 3-year local control rates were up to 65% with a median DFS of 7 months. So embolization, again, you can have either just embolization, TACE or radioembolization with good control rates in 3 and 5 years. And it all boils down to, I don't have to go to chemotherapy. And just to suffice to say that oligometastasis, a subset of patients, may have long-term survival with local and metastasis-directed therapy. Careful patient selection is the key. type of therapy really depends on performance status, extent of metastasis, and prior therapy. Multidisciplinary care is paramount. Thank you so much.
Thank you, Dr. Raja, for the overview. I would like to invite Dr. Jyoti Bajpayee, Senior Medical Oncologist from Tata Memorial Hospital, Mumbai, for conducting the panel discussion on personalized therapy in soft tissue sarcoma.
Dr. Vedant, I will invite the panel. Any of the panelists can take it. If Laskar sir is there.
The case, but for the difficult.
I think currently.
But are in your, what I understand?
Yep. So I don't use it. For the all cases, the
Hello, is it?
Yes, we can hear you now.
Yeah, my God, some technical issues.
Ma'am, should we share the slides from our end? Ma'am, is shared.
Yeah.
Yes. Please go ahead,
Dr. So as such, in the interest of time, I have not put the cases, and we will just open. We'll have an open discussion. Maybe I will start from the pathologist and the team. That are we there? Are we in the phase that for every patient we really require high throughput next generation sequencing, or you feel that it is still to go with the morphology, IHC, etc.
Madam, yes, madam. Am I audible?
Yeah, please go ahead.
For the all cases, the ancillary techniques, just like the RT-PCR or the hybridization techniques or the NGS, is not essential basically. The good number of cases we can diagnose based on the morphology and obviously the IHC. So IHC is very, very essential. For some tumors, definitely we need the help. Just in the small round cell tumors which are not showing the CD99 positive in a fishnet patterns or NKX 2.2 negative. So that group of the undifferentiated small round cell sarcoma, we need the help of the molecular techniques just to see that the BCOR translocation is there or the cis DUX4 translocation are there or not. And the similar things for some other sarcomas, just like some variant of the synovial sarcoma, where the immunos is not helping. In that case, the SYT
Sure. So I think the message from you is that at present the era has not arrived that we should do it for every case, but for the difficult to diagnose case wherein you're finding the morphology and IHC is not sufficient, you would send or you would want to take the advantage. Am I correct?
Exactly, madam. Exactly.
Yeah.
Exactly.
And from a medical oncologist colleague, I would like to ask Ashish or Piyush, or anybody in the team that are you agree with this, or you feel that era has arrived in the first line setting?
So, ma'am, I also do not feel, unless I have a clinical trial or access to these newer agents, I do not feel that I think the first and even so much in the second line, especially if the histology is chemosensitive, I do not consider NGS.
Right. So I think House is in agreement that although these tactics are really useful, but at present, due to various constraints, we are still using it judiciously and only in the difficult to diagnose cases or maybe in the later line of treatment. So what are the key determinants in selecting systemic therapy for patients with advanced soft tissue sarcomas? Again, another medical oncologist, I would say Piyush.
Ma'am, Dr. Devrat is there, the medical oncologist.
Sorry, Devrat. Yeah, sorry, Piyush.
Yeah. So I hope I'm audible. So I think a lot of factors come into play. Obviously, patient's symptomatology, disease burden, patient's general condition, the subtype of soft tissue sarcoma, the relative chemosensitivity or chemoresistance, and obviously with whatever little data that we have that Sameer has already shared, the histology-driven chemotherapy drugs that are available. I think those are some of the factors that I would consider before choosing therapy.
Right, but in the first line treatment, based on the current evidence, Anybody can answer this question. Do you feel that right now in first line we have enough evidence to choose histology-derived therapy, or is still the gold standard ifosfamide erythromycin is our, remaining gold standard?
I think currently erythromycin is the gold standard, and histology-derived therapy may be as good as erythromycin, but we do not have any evidence to say that they may be better. So I think a lot of patient-related factors. If there's a patient where you do not want to use anthracyclines, that is where you look at histology and you see if you can give something else.
Right. So I think this message should be loud and clear that although there is a lot of data which is emerging, from early phase studies and even from a lot of studies which are undergoing, but at present, based on the current evidence, we really do not have anything better than ifosfamide erythromycin combination, or at certain places erythromycin alone as well. It is our persistent gold standard. However, in second line and onwards, we have multiple options, and perhaps histologically derived or personalized medicine, precision therapy, all those we are practicing at second line onwards. That is what the current evidence suggests. So these are the options which has been discussed by the prior speaker as well, based on the trials that what are the drugs, and when the first line therapy fails, then eribulin, pasopanib, trabectedin, gem, dicarbazine, etc. in various tumor types. So, how many of you are actually using the online treatment decision tool for advanced STS? In breast, it is quite common, but are we really, versed or started using this online tool for advanced STS as well? Anybody can take it up.
So I don't use it. I'll be honest. I've never used it so far.
Okay. So again, this is also one of the development towards personalized therapy, but again, it is not so commonly practiced, although it is useful. As in breast, it is not so commonly used at present. So my another question would be that in which cases you choose doxorubicin versus a combination or another therapy. How you decide in your clinics that this particular patient should be only given single agent or a doublet, and what is your common practice?
So in my practice, for most patients who have symptomatic disease or a high disease burden and the patient is fit, I would offer a combination of ifosfamide doxorubicin. Obviously, with the caveat that there's no evidence to suggest that the combination leads to a survival advantage compared to a single agent. But those with lesser disease burden, lesser symptoms, single agent doxorubicin could be a choice.
So your majority of the patient actually receive the doublet. That's what I understand.
Yeah, most of my patients, if they are fit, I end up giving them a doublet.
So if they are fit, or if they are, apart from being fit, if they are having a different, much more burden of the disease or fast pace, both the factors you will take into account.
Rapidly increasing, high disease burden, symptomatic and fit.
Right. So now from here we'll move on to the second line and beyond treatment consideration. So if you're, so these are the options which we have discussed. But are in your, when you are working in clinics, are you strictly going by these, criteria? For example, if I say, are you using pazopanib for strictly the patient who are non-adipocytic? And what is the, house experience in this regard?
So, ma'am, in second line, usually I think patients have poorer performance status. They have more symptomatic, and they're unable to tolerate especially if they've had doxo ifos. Generally, after that, they do not tolerate the doublet very well. So we look at histology. That's important. So all the L sarcomas, maybe trabectedin, eribulin. Somebody who prefers an oral therapy wants some time off injections. Many times we sometimes use pazopanib even as maintenance, kind of as soon as you finish your chemo and then this patient will rapidly regrow, we use pazopanib. gemcitabine with or without docetaxel again is a toxic regimen. So we would, unless it's a uterine leiomyosarcoma where we may want to use it upfront, we will use those. So it's basically very individual decisions which are made. Majority of my patients are on single agent in second line.
So I think a very important point you made, Ashish, that although the histology sedation is for one particular subtype is more sensitive to one, but it is not very tight compartments, and it is generally composite decision between the various factors, as you rightly mentioned. And also we see in clinics many times, and also there is an evidence for pazopanib working in aducanumab in a phase 2 trial. So how people choose their patient in phase 3, that also decides the label indication. But many a times we see in clinics, as you rightly said, some patient opt for an oral regimen, and then we see that it is working. And as far as it is backed up by at least a phase 2 data, it is good enough in sarcomas. And also similarly for eribulin, if I say the label indication is for only leiomyosarcoma. But if Devrat, you want to comment upon that particular type?
Yeah, so I agree. While I think the label indication is different across the world, and while the data was very robust for liposarcoma, I think for leiomyosarcoma, while the approval is there in Europe and some parts of Asia, the data was not so robust. So I would agree with Dr. Ashish Singh. I think it's my own experience with the combination. It's the fitness of the patient, it's patient's preference, and increasingly in a private setting also the cost of medication that comes into play.
Yeah, absolutely. So all the points are well taken, and you rightly said that it is approved for both L type of sarcomas in Japan and some other European countries, while not in other part of the world. So we have to take every factor into account, and not only the label indication. That is probably the message of the house. So what about the systemic therapy for chemotherapy resistant STS? This is where the personalized therapy more come into vogue, like clear cell sarcoma or some other perivascular epithelioid cell tumor. So there are some newer agents, and in the interest of time, I have shown this slide as well, and I want comments from the house. What is your experience of using such drugs, and what is the comment upon the literature?
So, the newer drugs, I mean, especially if it's given for the right patients, we have had very good response. Especially, I've had patients with alveolar soft part sarcoma who have done well, not only on sunitinib, we've even used sorafenib in many of them. We've had patients with chordoma who have gone on imatinib for a very long time. So we are seeing, so even pazopanib with uterine sarcoma. So these are all, so there are few patients who are really good responders, but majority of them do not. So, but then response rates in alveolar soft part sarcoma of 40-50% is pretty good. I mean, chemotherapy doesn't give you that response in that disease. So
Absolutely.
it's yeah.
Right. So with the newer TKIs, the indication of really expanding, and in many difficult to treat tumors, we are seeing good responses, as you rightly said. Not only sunitinib, pazopanib, sorafenib, some other kinase or inhibitors also are into practice. One very important point about larotrectinib, which was the news of the ASCO, and you want to comment upon Devrat on this, the NTRK mutations and their inhibitors.
Yeah, so I think this is a very promising fusion, the NTRK fusion. And in fact, I have one patient who's actually solitary fibrous tumor, underwent a NGS and has a NTRK fusion and is on entrectinib, which we were able to get hold of, and she responded beautifully. So very promising. Again, a very small subset of patients would actually harbor this mutation, but very promising. And we have larotrectinib and entrectinib. I think probably a little bit more data with larotrectinib in terms of efficacy, tolerability, and robustness of data. But I think both the drugs are approved in
right. And even you can get on, the important point is even you can get on compassionate access if you really can convince, and if there is a mutation present. So I think pathologists and the people who are involved with NGS, they are very, very important people to expand our armamentarium. If there is a mutation present, we can convince the companies to provide these drugs, these life-saving drugs on compassionate ground. And as you rightly said, that if mutation present, these drugs are working very well, and there's a good data which is emerging. Now, for my surgical colleague, and sorry Piyush, I wanting to take you into medical oncology domain, but now you can please comment from your original site. So what is the personalized precision therapy and surgical as far as the surgery is concerned?
Basically, as far as surgery is concerned, we take in basically so many factors. The first is grade of the tumor, the size of the tumor, the resectability, upfront resectability of the tumor, whether we will be able to preserve the limb with functionality or not. The morbidity of resection. Sometimes the resection is massive, so much of tissue loss is there. The reconstruction is to be required. That may basically cause a delay in basically taking the adjuvant treatment. So if we take all these things in consideration, if we feel that tumor burden is too large, the grade is high, so I will basically prefer the patient to undergo preoperative radiation followed by surgery. If I feel the tumor is too close to vessel for me to be comfortable taking it out with a clear margin, or if the tumor is going to basically lead to a very large resection which will basically lead the limb to be dysfunctional, or we need an amputation. So in this condition, I will prefer to basically go for preoperative radiation and then followed by surgery. And plus also if I am going to have a resection where there is a chance of basically doing an oncoplastic, I had a of having a dark sarcoma in the thigh which I to have a limb preservation in basically tuned with a plastic surgeon. The flap eventually went out and we had a very bad experience. So from that experience we realized if we basically preoperatively if you have a plan of putting up a flap, better to go for preoperative RT followed by surgery.
But you never want to involve us. You are only talking about pre-op RT. You have no belief on neoadjuvant chemo or any therapy.
Only in basically chemosensitive sarcomas, which are basically very few. So in those cases, yes, I do involve medical oncologist. And as per my hospital policy, we basically put up a tumor board. We decide in the tumor board, radiation oncologist, medical oncologist, surgical oncologist all combined together. We take a decision on what therapy to basically go on. And that is the way we basically move.
Right. So there is always debate and the tumor boards are
There is always a debate. There is always a healthy debate.
Correct.
Lot of argument and eventually lot of study and then we eventually reach to a conclusion which is
so Devrat, a quick comment on how much time I'm having, Randeep. A quick comment on neoadjuvant, Devrat.
Yeah, so I would consider it for the chemosensitive subtypes. Those are the settings if the tumor is very large. That's the setting where I would be willing to offer. Otherwise, for the less chemosensitive subtypes, I think pre-op RT is probably the way to go, and neoadjuvant chemotherapy is not what I would offer.
Right. So I think we have
5
to be,
minutes, Dr. Jyoti. 5 minutes you can take.
Okay. So basically, I think the time has arrived. Time is not arrived for every patient to put on NTS and every patient to put first line on precision therapy. But I think the time is really arrived wherein we should consider that neoadjuvant and adjuvant, both the concepts are actually we can extrapolate, and the tumor sense, the chemosensitive subtypes wherein we think that adjuvant would work. There is a room to think that neoadjuvant will also work. Of course, we don't have that kind of robust data, so we have to be very vigilant. We have to monitor very stringently, and perhaps giving neoadjuvant is kind of an in vivo drug trial as well, so that we can really find out that these therapies are even later on they work when we actually play blindly. So, one word about immunotherapy, Ashish. So these were the SARC-028 and Alliance trial. Your quick comment on that. What do you think?
I think we're still scratching our heads on which sarcomas respond to immunotherapy, and a lot of these trials, the immunotherapy has not been given alone. They usually combined with either lenvatinib or with some other inhibitor. So my short comment will be, as a single agent, I don't think immunotherapy is going to help a lot of patients, but in combination, it may have a future.
Right. So basically, so far the data is that perhaps we are actually learning to tame the beast, and we need to derive some more strategies so that we can actually revoke the immune response in this difficult to treat tumors. And we have seen in some very difficult tumors there is some signal has coming up. So like Merkel cell, which was very difficult to treat tumor, and there's a signal is there. So perhaps it's a time bound phenomena wherein we will actually learn that which modality to combine, whether we can take advantage of chemotherapy or some other agent TKIs or some radiation. So for abscopal effect, I want a comment from Dr. Indu Bansal. What do you think? Abscopal effects can work for sarcomas along with immunotherapy?
So definitely, abscopal effect has definitely been seen for patients who sarcomas with lung metastasis, wherein you give very high dose of radiation to the